Today we will read about the neonatal X-ray chest. The neonatal X-ray chest is absolutely different as compared to the adult chest. In adult chest, what we find into the neonatal chest, especially the structure which is the thymus, that is not there at all. And the thymus is seen into the neonatal chest where we are confused that what it is. It can be a mediastinal mass or it is something. It is confused by the mediastinal mass. So always into the neonatal chest. The neonatal chest is a chest is taken into the first 28 days of the age of the infant. This is the neonatal age. So in this neonatal age, generally what we see is the thymus, which is a lymphomatic organ and which is responsible for the T cell immunological function. The normal thymus is generally a soft tissue structure which is having the very smooth border, soft tissue structure and very smooth border, and it is present into the anterior mediastinum and to the superior mediastinum. And this structure, the thymus, which is seen into the neonatal chest, this is seen only up to the 3 years of the age. After 3 years, generally it regresses, but most of the cases this thymus is not seen in the X-ray chest, but in only 2% of the cases it may be seen later of the 3 years of the age. But when we take the CT, it can be seen up to the 20 years of the age. The thymus, because this is a soft tissue structure, but it does not cause any mediastinal shift. If there is any mediastinal shift, always think about this is not thymus, how much the thymus is enlarged. It is not the region, but the region is something else. Some other mediastinal mass must be there. Now, in X-ray, what we find? In X-ray we find a soft tissue shadow which is into a triangular cell shaped. Cell is boat like a now, and that is also known as the thymus cell sign. And this is seen generally towards the right mediastinum, and many times it can be seen only on the also on the left mediastinum, or it can be seen bilaterally. It does not cause any mass effect, does not cause any effect on the vascular structure or airways, and the size can be vary with the inspiration. Now you see, this is the X-ray chest where you find on the right side there is the cell sign. This is the this is the soft tissue structure which have the very regular border, which has the very regular border. This is you see the cell sign, very regular border, and this is the heart. So this is the cell sign, and this is the normally seen in normal infant. Another, what we see the sign, this is the thymus shadow, and here this is the cardiac border, and in with this cardiac border this is the thymus notch sign. This is also seen on the right side. This is also a very common variety which we can see into the thymus. Another, this can also be seen on the both side. The thymus notch sign can seen with the thymus on the both side, right side also and the left side also. And many times we find the wave sign. The thyroid border is like the wave, and this wave sign can be seen on the left side, can be seen on the right side. So this is the thymus structure. We should never confuse with the mediastinum. We should never confuse it. It doesn't shift the mediastinum and never be cause the shift, and it is not a mediastinal mass. So we should always be aware with its normal size, normal appearance. Now we come to the common neonatal medical diseases. In neonates, the medical diseases are totally different as compared to the adult. Adult, we find the diseases something like pneumonitis, infection, pleural effusion, consultation. But here, the diseases are which only seen in neonates, not in adult. This is the hyaline membrane disease, respiratory distress syndrome, insufficient. This is the hyaline membrane disease. First is the hyaline membrane disease, second is the transient tachypnea of newborn, another is the meconium aspiration syndrome, and another is the neonatal pneumonia. These are the 4 very common diseases which we find in neonates. The surgical diseases are tracheoesophageal fistula, congenital diaphragmatic hernia, congenital cystic adenoid malformation, congenital sequestrated lung disease, and congenital lobar emphysema. These all are the congenital neonatal surgical diseases. Now we will discuss the congenital medical diseases. First is the hyaline membrane disease. What is hyaline membrane disease? Hyaline membrane disease is generally it is, as the name suggests, it is also known as the RDS, or the respiratory distress syndrome. Why it is? Because it is causing the respiratory distress. Second is, it is also known as the lung disease of the prematurity, because this disease is present in the prematurity, so that's why it is also known as the lung disease of prematurity, and also known as the surfactant deficiency disorder. Why it is so? Because there is the deficiency of the surfactant into the lung alveoli. This respiratory distress syndrome is a relatively common condition that occurs in preterm neonates. That is a very important. This disease always find into the preterm, not in term or not in post-term. When the fetus is term, don't think about the hyaline membrane disease. Always whenever preterm, then you think about the hyaline membrane disease. This occurs because the insufficient production of the surfactant. What is this surfactant? This surfactant is developed at the age of 35 years of the fetus, and after that. Before 35 weeks, if the fetus is below the 35 weeks, definitely there is no production of the surfactant. Hence, this disease develops. After the 35 or 36 weeks, this disease does not develop because there is the development of surfactant. Hence, there is adequate amount of surfactant, so we don't find this hyaline membrane disease. Now, the clinical presentation, what we find is, there is always this clinical presentation appears into the first few hours after the delivery, into the premature baby. Signs are tachypnea, expiratory grunting, and the nasal flaring. The infants may or may not be cyanosed, and the substernal and intercostal retraction is there. That is the main finding which we see into the clinical presentation. Now, what is the pathogenesis? Pathogenesis, as we have seen, that there is the surfactant absent. When the surfactant is not there, there is the rise in surface tension into the alveoli. The surfactant has the role in alveoli, and because it is not there, and because of that increased surface tension, there is the collapse of the alveoli. And when the collapse, all the air disappears from the alveoli, and this causes the cell damage, causes the cell necrosis, and ultimately there is the mucous line into the alveoli remains there. And when the alveoli are collapsed, these are the microscopically we visualize, but lungs are collapsed macroscopically. We can see our naked eye that lung are collapsed, lungs become small in size, and it is because of the diffuse type of the adhesive atelectasis, because of the absence of surfactant. So, the radiological picture what we find the diffuse bilateral symmetrical granular opacity. Bilateral symmetrical opacity and the small thorax, because the lungs become small. So, the thorax is also small. Air bronchogram remains there, because this is the disease of alveoli. So, air bronchogram is seen. Low volume lung, volume of the lung is small. Hyperinflation is not seen unless patient is intubated. Hyperinflation is not the sign. And when we treat with the surfactant therapy, the patient shows the improvement. Now, this slide is very important. We must remember that hyaline membrane disease seen in preterm, seen bilaterally, symmetrical and granular and ground glass appearance seen into the X-ray. This is the X-ray picture where you find these are the ground glass opacity, symmetrical reticular nodular opacities, air bronchogram. You see air bronchogram is there, and blurring of cardiac border and the diaphragmatic border. These are the typical finding of the hyaline membrane disease, but this is seen into the premature children. That is the important. Now, this is the grading, grade 1, grade 2, grade 3 and grade 4. In grade 1, what we see that this is the very earliest form where subtle ground glass opacity is seen, minimal reticulonodular shadows and no hypoventilation, and diaphragmatic and cardiac borders are well visualized. In grade 2, what we see that significant the opacity increases, the air bronchogram also seen, but this is the central type. Cardiac and diaphragmatic border are also little bit ill defined, not very clear. Grade 3, you find that finding are more opacities, more ground glass opacity, and cardiac border and the diaphragmatic borders are somewhat obscure. And in grade 4, what we see is that almost this is the opaque lung. You cannot see the air bronchogram, you cannot see the diaphragmatic border, and you cannot see the cardiac border. So this is the grade 4 of the RDS, grade 4 of the hyaline membrane disease. Now the management in grade 1 and 2, which is the minor disease, there is no need of intubation, no need of the ventilator, no need of the surfactant therapy, and only oxygen support. Oxygen support is needed, patient become okay. When grade 3 or 4, it need intubation, it need ventilator, and surfactant therapy is very much necessary. Then only patient improve, and patient improve with this therapy almost completely. These are the X-ray where we find the pre-surfactant therapy. The patient see bilateral grade 3 and 4 RDS or the hyaline membrane disease, but when the surfactant therapy is given, you see the lungs are well inflated, well normally visualized. So this is the treatment. Now second condition is the transient tachypnea of the newborn. In this transient tachypnea of newborn is the another condition which we find into the neonates, and this is because of the retained fetal fluid or the it is also known as wet lung disease. During the delivery, there is complete fluid is not drained from the lung or from the body. So this disease occurs. This generally disease present with the tachypnea. As soon as the patient delivers, we find that patient has the tachypnea, and this tachypnea is generally in the form of respiratory distress and seen in particularly term and near term. But this disease remain up to the 48 hours or maximum up to the 72 hours. After the 72 hours, this disease automatically regresses and the fetal and the infant become cured. There is delay in clearance of the pulmonary fluid into the newborn lung. That's why this transient tachypnea of the newborn disease occurs. It is seen in term infant. We must remember it's seen in term infant, not in preterm. This is seen with the history of cesarean section and the precipitate labor. This is very important. If the fetus is term infant, fetus with the cesarean section, and patient has the tachypnea, this is definitely TTN, that is the transient tachypnea of the newborn. Now the plain radiograph, the finding is of the similar like the pulmonary edema, because this is a wet lung disease. With the wet lung disease, there is the fluid remains into the lung. So there is, you find interstitial edema. Interstitial edema, there is predominantly perihilar shadows. Perihilar shadows are seen, and with that minimal pleural effusion is seen, and many times there is mild to moderate cardiomegaly can be seen, and further if the fluid is more there is a perihilar alveolar opacity is seen. That is the alveolar edema. Interstitial edema, then alveolar edema, then there is the pleural effusion, and sometimes the fluid is seen into the fissure also. And generally after 48 to 72 hours of delivery, the chest become normal. This is an important slide where the patient has the history of full term, having the cesarean section, having bilateral and symmetrical appearance, and diffuse airspace, fluid in the fissure, and the effusion. The disease is there. So this is the TTN or the transient tachypnea of the newborn. You see the reticular, these are the linear opacities such as the interstitial edema, this is the fluid into the fissure, and this is the minimal pleural effusion. So all these findings are suggestive of transient tachypnea of the newborn, which itself finish into the resolve into the 72 hours. Now another disease which we are going to discuss is the meconium aspiration syndrome. What, as the name suggests, there the respiratory distress occur in a secondary to intrapartum and intrauterine life because of the aspiration of the meconium. The fetus aspirate the meconium, and that's why their meconium aspiration syndrome occurs. It is seen in term and post-term infant. That is important. It is seen with term and post-term infant, And second important thing is the history of meconium stained fluid at birth. When the delivery occurs, the amniotic fluid which is drained out, you find that is the meconium stained. That is a very important. If the meconium stained fluid is there, baby has the chances to develop the meconium aspiration syndrome. It is depending on the length of exposure, meconium skin staining also can be seen. Neonate typically present with the respiratory distress, hypoxia. These are the clinical features, and because of the aspirated meconium, there is airway obstruction and the chemical pneumonitis. Chemical pneumonitis occurs in the patient. The X-ray picture, what we find, there is the increased lung volume in the term infant, hyperinflated lung, area of asymmetric patchy hyperinflation, rope-like perihilar opacities, and the bilateral disease seen middle 2/3 of the lung. Pleural effusion may be rare, very rare. Complication pneumothorax, pneumomyelitis, pulmonary interstitial emphysema. When we see the X-ray, we find there is the radiograph of the full-term infant, where you see the mucal aspiration as the coarse interstitial shadows infiltrates into the right lung and presence of pneumothorax on the left side. So this is the radiological picture which we find. So treatment is very simple. There is the suction of secretion, intubation, ventilation, but mortality can be seen into 10 to 20% of the cases. Why it is so? Because meconium, when reach into the pulmonary parenchyma, it causes the severe parenchymal pulmonary disease. That is because of the chemical peritonitis. And ultimately, when this does not recover, the mortality can take place. So this is the slide which differentiates all these three conditions. This is RDS, that is respiratory distress syndrome, or because it occurs because of surfactant deficiency. It occurs into the preterm, as we have said. It is seen in the preterm delivery. Tachypnea, hypoxia, cyanosis is there. Homogeneous infiltrate, air bronchogram, decreased lung volume. This is the radiological finding. And surfactant deficiency is there. TTN, that is the transient tachypnea of the newborn. This is seen into the term. That is the important seen in term. And persistent lung fluid is there. The lung is wet, and there it is seen into the cesarean delivery. Tachypnea is the clinical picture, and parenchymal infiltrate, wet lung, and intralobar fluid and pleural effusion is the radiological finding. Into the meconium aspiration syndrome, it is seen during the term and during the post-term. That is because of the lung irritation, meconium stained skin, post-delivery seen. Tachypnea, hypoxia is the clinical picture, and patchy atelectasis and consolidation is seen. So all these three diseases can be differentiated very well. Another fourth condition which is very commonly seen and also seen into the adult, that is the pneumonia. But it is the neonatal pneumonia, and that occurs within the first 28 days of the life. That is seen because of the infection occurs in utero, during the delivery, and during the first 20 days of the life. Most common etiology is the bacterial infection. It can be viral infection, protozoal, tubercular, or the fungal infection. The sign symptoms, you find there is a tachypnea, chest recession, apnea, respiratory distress, cough, neutropenia. Neutropenia is there. That is a very important point. We must know. Neutropenia find, and with temperature instability. Patient has the fever, but very unstable temperature. Maybe there, may not be there. Now, radiological finding, you find into the neonatal bacterial pneumonia, the lung volume is normal or increased, asymmetrical perihilar densities, unilateral or bilateral, may have the pleural effusion, infection, reticulonodular appearance, and rope-like perihilar opacities. Complication, pneumothorax, pneumomediastinum, and the pneumatocoel, that is seen. This is the radiological picture which we see is, this is the AP chest of the infant of the before the 28 weeks, it delivers at 28 weeks. These are reticulogranular opacities are seen with distal air bronchogram. You see the air bronchogram is there, and when the culture of the blood is done, tracheal aspiration, it is the, we find the Haemophilus influenzae. So this was the infection, which proves that this is the bacterial pneumonia. And this is the X-ray picture where you find the progressive lobar consolidation, you find cavitation, necrosis, and these are the pneumatocoel and minimal pleural effusion that you may see in these conditions. So this is all about the medical disease In the neonates, these all diseases are very much different as compared to the adult chest, and we must know each and every disease. In these all diseases, the history is very important. Always history always play a very big role. We must first ask the history, and according to the history, we should do the differential diagnosis. Thank you. Thanks a lot.